Hello, this is chapter 14, and this is going to be micro lecture number 4, and this is just going to be the cranial nerves. When I say just the cranial nerves, there's only 12. So the best way to memorize these is just memorize 1 through 12, memorize their names, and then make a little column next to it that says, is it a motor, is it going to be sensory, or is it going to be both? And if you kind of do that, you will be able to memorize cranial nerves for the rest of your life. So let's get started. So the brain must communicate with the rest of the body. Most of the input and output travels by the way of spinal cord. There are some special ones, like these 12 pairs of cranial nerves that arise from the base of the brain. They exit the cranium through foramina, or holes, and lead to muscles and sense organs located mainly in the head and the neck, except for the vagus. That's going to go all the way down, and we'll kind of look at that one. That one's special. So most of the fibers of the cranial nerves begin in the nuclei of the brainstem. You're looking at pons, the medulla oblongata, the midbrain, around that area. And when we look at the actual brain and the cranial nerves, they kind of have an organizational pattern that's pretty easy to kind of recognize. They're going to be sensory fibers, begin in the receptors, located mainly in the head and the neck, lead mainly to the brainstem. These sensory fibers for proprioception may travel to the brain in a different nerve or motor nerve. So let's kind of look at the classification of them. So some cranial nerves are classified as motor, which means they act on muscles. Some are going to be sensory. So if somebody touches your face, or somebody, if a bug lands on your skin, it's going to be able to sense that type of thing. And some are mixed, which means they do both. So the sensory ones, 1, 2, and 8. Motor is 3, 4, 6, 11, and 12. And mixed is 5, 7, 9, and 10. If you're not comfortable with Roman numerals, now's the time to become comfortable with Roman numerals, because cranial nerves are usually going to be shorthand as CN1. So something's going to be wrong with that patient's ability to smell. So this is going to be kind of looked at. You should memorize 1 through 12 and what their names are. So let's kind of take another look. So I kind of showed you, where everything is and what's everything going, but 1 is going to be the olfactory nerve. Olfactory, olfaction, that's going to be breathing. If you go up to number 2 is going to be vision. So number 2 is the optic nerve. Optic nerve is going to be taking all the signals from the retina, the different layers of the retina. The output neuron of the retina is going to be the ganglion cells. Those axons are going to make the optic nerve, and they're going to travel all the way back to the brain where you can sense vision. Then you have number 3. If you kind of look around here, they're kind of all over the place. But 3 is going to be ocular motor. Ocular motor means it moves the muscles around the eye. It's not bad. Number 4, trochlear nerve. Trochlear nerve, you're going to learn this when we do eye and the ear and the nose and the sense organs. They have a little structure right here called the trochlea, where this muscle called the superior oblique muscle goes through. The trochlear nerve supplies the innervation for the superior oblique muscle in the eye. So ocular motor does eye movement, trochlear nerve does eye movement. Now let's move on to 5. So number 5 is going to be, 5 is the trigeminal. Trigeminal is going to be right there. It's going to be a very large one. And then after the trigeminal is going to be 6. 6, you have to go all the way back up to the eye again, because that's going to abduct the muscles of the eye. So it's called the abducens. So abduction of the eye is away. So this is medial, that's lateral. The abducen is going to be the lateral rectus muscle that abducts the eye. So that's another eye movement cranial nerve. Then after the abducens, you go to the facial nerve. Facial nerve is mostly going to be the facial muscles. So you see down here, all of those muscle movements. Facial nerve is going to do sensory nerve for the tongue and the soft palate. So it's also mixed. The trigeminal, you see most of the muscles in the front of the face are going to be trigeminal. A lot of the muscles in the front of the face are also going to be facial. Well, sorry, this is going to be sensory of the face and muscles on the side for the trigeminal. Then after the facial, you have the vestibulocochlear. So vestibulocochlear does the cochlear nerve and the vestibule of the inner ear. The vestibule is going to be doing balance and equilibrium. The cochlea is going to be doing a lot of the hearing. So vestibulocochlear is doing hearing and equilibrium. Then after vestibulocochlear, glossopharyngeal. Glossal is going to be tongue, so it's going to be down here. Glossopharyngeal, that's going to be number 9. Number 10 is this one, where you see it going into the throat, into the trachea, the esophagus, the lungs, the heart, the stomach, the intestines. The vagus nerve, vagus for Latin for wanderer. So this wanders all throughout the body. That's why if you ever get a vagal reflex where you're about to pass out by giving blood or something like that, you feel something in your lower gut, then you feel it in the stomach. Your breathing might start to change, your heart might start to race, your throat will then start to dry out, and then eventually you'll pass out because it's just working its way back up to overstimulation of the vagus nerve. Then you have the accessory nerve. Accessory nerve, sometimes called spinal accessory nerve, is going to be doing muscles in the neck. Then finally, hypoglossal nerve is going to be the tongues of the muscle, and down here for the hypoglossal. That's number 12. So this is kind of the chart I told you to look at and memorize. The reason why Roman numerals are important, names are important. If you get the Roman numerals, you get the names, very, very, very easy. Then you're going to kind of look. Is it sensory, motor, or is it mixed? And then what does it do? Most of these are pretty easy. If you know one little thing about it, it's very easy. The trigeminal and the facial is going to have multiple branches. You don't need to know the branches for this class or the exam, but you do need to know that the trigeminal is mixed. It says sensory and it says motor. And then the next slide has the abducens, facial, vestibulocochlear, glossopharyngeal, vagus, accessory, and hypoglossal. Again, is it motor? Is it mixed? Roman numeral. And then what is it doing? And now when we look at it, this is kind of what I wanted to show you. The way the cranial nerves are named, they're anterior to posterior and then superior to inferior. So 1, 2, 3, 4, 5. You can kind of see 5. Then you have 6, 7, 8, then 9, 10 right there, 11 right there, and then 12. But you can see them all. This is the pons right there. So just below the pons and right on the sides of the medulla oblongata, this is where it gets really confusing. So the first 5 are easy. 1, 2, 3, 4, 5. Then down here they get a little tricky. But for the most part, they're very easy to kind of look at. So now let's look at what each one does. Olfactory, I talked about it. Sense of smell, very easy. Damage to it, you can't smell anymore. Number 2, vision. So it's going to be the retina and then the output neurons of the ganglion cells that are going to create the optic nerve that makes the optic nerve to the optic chiasm, which we talked about when we did the brain. Ocular motor, eye movement. It's going to control the muscles that turn it up, down, medial, as well as controlling the iris and lens, allowing light in and out. Trochlear also, but it's going to be doing the superior oblique muscle, which is going to go through this little structure called the trochlear. Trigeminal nerve, it's the largest cranial nerve. It does sensory on the front of the face. You can kind of see where the sensory is. And then the motor part is going to be the motors for, or the muscles for chewing, and also the temporalis muscle, which is going to be up here in the temporal region. Abducens, abducts the eye. lateral oblique, or sorry, lateral rectus muscle. Then the facial nerve is majority going to be motor, and it's going to be all of those muscles on the superior portion of the face, and then taste on the anterior 2/3 of the tongue. So it is going to be mixed, but most of the fibers are going to be for motor, and there's that last little bit of sense of taste. And this is kind of where the branches are. You don't need to go into that much detail. But by knowing them, you can know which part of the facial nerve is damaged. Sometimes you can have eye drooping and stuff like that, and this can be go back to different viral infections within the different branches of the facial nerve. Vestibulocochlear, mentioned it. All the nerve fibers coming from the vestibule is coming where balance is going to be in the inner ear. All the nerve fibers coming from the cochlea are going to be doing hearing. So hearing and equilibrium is what the vestibulocochlear does. Glossopharyngeal, swallowing, salivating, but it's going to be in the back right here in your pharynx and in your tongue. The vagus nerve, that's the weird one, that goes to the lungs, it goes to the heart, it goes to the throat, it goes to the liver, stomach, spleen, kidney, large intestines, small intestines. So damage of this will kind of work its way back up, and sometimes if you do damage it or you do overstimulate it, it can cause you to pass out. An accessory is going to be in the neck. That's why it's sometimes referred to as the spinal accessory. And then finally, the hypoglossal is going to be the tongue, and the tongue movement for speech, food manipulation, swallowing. If both are damaged, cannot protrude the tongue, so you can't stick it out. If one side is damaged, it deviates towards the injured side. So that's why they go, ah, and they make you kind of stick your tongue out. All they're doing when they're doing all these different types of tests is seeing if you have any type of nerve damage. And another thing to kind of think about is if you do have some type of nerve disorder. So you can have trigeminal neuralgia, and this is recurring episodes of intense stabbing pain in the trigeminal nerve area, mouth or nose, pain triggered by touch, drinking, washing the face, and the treatment may require the cutting of the nerve, because this is where you get this really intense pain within the trigeminal nerve. The one that's most likely to see is going to be Bell's palsy. This is a degenerative disorder of facial nerve, causes paralysis in the facial muscles of one side. This can be caused by a virus. This can be a degenerative disorder that can get worse over time, but pretty much a nerve gets infected or it gets damaged on one side, and it just kind of causes drooping on one side. It appears abruptly within a day or two, and then usually people are fully recovered between 3 and 5 weeks. And that concludes this micro lecture on chapter 14.